So we've begun recording, and that's my key to get us started. I am channeling Josh Gutman, um, who is one of our leadership team and was going to be doing this introduction tonight. He is both got a daughter in labor and has a flat tire on Route 95. So our thoughts and prayers are with him, and particularly with his daughter, so that she has a quick. We hope that she has a quick and painless labor with a beautiful baby to hear about in the next 24 hours. Josh, we've got our fingers crossed for you. My name's Michael Fine. I'm the president of Primary Care for All Americans. Um, and I'm really happy to say thank you to everybody for being with us tonight, and to welcome this amazing panel as we address the important question, how we pay for primary care in Rhode Island. Um, I don't know why I've got an echo, and I apologize for that. Uh, anyway, hopefully that echo seems to have gone away. Thank goodness. So thanks for joining. We have over 200 people from every town in the state of Rhode Island working with us on getting primary care to all Rhode Islanders. And it's worthwhile reflecting on the incredible momentum we built in the last year. We now have between 5 and 7 local work groups working in Rhode Island, trying to get people in their own communities, trying to get primary care to everyone. And last year we worked together to really move things along at the state level, together with many of the friends and colleagues who are on this Zoom tonight. Together, we helped fund a new residency in Woonsocket. Together, we helped get the state to add another $30 to $40 million a year to make sure that primary care funding for Medicaid was at the level of Medicare, which is really a big deal, and to improve the funding of primary care loan repayment, as well as passing legislation that dials back pre-authorization at least a little bit. Remembering that the 3 challenges for primary care, and there are, I think of 3 major challenges. One is reimbursement, the second is workforce, and the third is workload. Those things are the things that we can work on together. But despite the progress we made last year, we still face a huge primary care shortage in Rhode Island. We're looking at the largest jump in health insurance cost in 5 years, and we are expecting that between 44,000 and 67,000 people are going to lose Medicaid or insurance through HealthSource Rhode Island in the next 10 years, all at the time that the state faces another multi-million-dollar deficit. Your participation in tonight's discussion is more important than ever as we try to figure out what our legislature can do to help, remembering that our local work groups are really what changed the reality on the ground in our neighborhoods and communities. That is happening in an amazing way. So if you want to join a local work group or start a local work group, please let us know. We really need you. Transformation starts in the communities, and communities are the testing grounds for innovative policies and programs that we can scale to the state and national level. The primary care for All Americans Rhode Island leadership would like to give special thanks to Margaret Grady, Deborah Udapo, and Brian Kaiser for making tonight's discussion happen. And now it's my great pleasure to introduce my friend and our moderator for this evening, Marie Ganem, who's the former health insurance commissioner, an adjunct professor at Brown, a longtime health policy advisor to the state Senate, and a wonderful human being. And to extend my sincere thanks to all of the presenters for tonight's event. Take it away, Marie.
Thank you. Thank you very much, Michael, and thanks for that introduction. and for hosting this tonight. I want to start with a couple of housekeeping issues. First, thank you to everyone who's joining. If you could please put yourself on mute to make sure that we don't have any background noise or any echo, that would be very much appreciated. And then secondly, if you could identify yourselves, everyone who's participating in this call, and identify which community you're from, whether it's a community in Rhode Island or outside of the state, so we get an idea of who's represented on the call. That would be great. Thank you. In addition to that, while we do that, we're not going to use professional titles. Everybody's going to be, feel as though they can participate in the conversation as equals. And so we're going to focus mostly on being here, being together, respecting each other, valuing each other's ideas, and looking for a community-based movement to move forward on primary care. The folks who are going to be on the panel tonight are going to be very, very interesting. We've already had a bit of a chat, and we know how vested they are in this issue. First, Elena Nicolella, who is currently the CEO of the Rhode Island Health Center Association. It's called the Healthcare Association, but it's Health Center Association, right? She's a former board member of the Providence Community Health Center, and she was our state Medicaid director for a while. She's very knowledgeable and has a lot of history in the Medicaid program. Secondly, we're going to hear from Frank D'Alessandro. He's a Rhode Island native. He's a general internist and is the founder of MDRI, which is a 14 clinician practice in Johnston, Lincoln, and East Greenwich. And it's growing. And you'll hear from both of them about their perspective, not only on what's happening on the ground today in primary care, but what they hope we can influence and work toward with the legislature in the upcoming months. So I'm going to introduce Elena first, if you want to kick it off. Thank you.
Sure. Thanks so much, Marie, for that nice introduction. And I noticed I was looking at some of the attendees. So several people know a lot more about community health centers than I'm going to talk about. I see Paul George and Andy Solon and Phil Chan. So it's a nice number. So if I'm going to be a little bit less formal than maybe I had originally intended to do. What I'd like to do in my time is one, just do sort of a level set on what community health centers are and why they're this pretty unique component of our overall health care system, how they're paid, and some of the lessons that we've learned over the last few years in trying to address the way that they're paid. And then I will talk a little bit about some of the ways that we at the Health Center Association think about legislation and what to advocate for, and really focus on the question that Marie laid out for us, which is how could the legislative process protect primary care practices by changing the way that we pay or enhancing the way that we pay them. So first, a little bit about community health centers. For those of you on the call who may not be that familiar with community health centers, they're also called federally qualified health centers. I'll refer to them as community health centers. They receive grants from the federal government that require that they fulfill certain obligations, and these obligations set them apart from private practices. A couple of these specific requirements are they have to exist in areas that are medically underserved, or there's a shortage of health care services. They have to serve the needs of everybody in the community. So regardless of your immigration status, your income, your insurance status, currently, we're hopeful that this doesn't change with the new administration. Currently, community health centers are required to take all comers. They have to be governed by a board of directors that's made up with a majority of patients. And that is to ensure that the health centers are meeting the needs of their specific communities that they're required to serve. And connected to that is also this requirement that they provide enabling services. These would be services that help patients access the care they need transportation, interpreter services, care management. So with that goal in mind, all of the health centers in Rhode Island not only provide primary medical care, but they also provide dental care and behavioral health care. So just very quickly, we've got 8 health centers in Rhode Island. I'm going to name them because some of them you may know and may be surprised to learn that they're a community health center. We've got Well One, Wood River Health, Blackstone Valley Community Health Care, Thunder Mist, Providence Community Health Centers, Comprehensive Community Action Program, or CCAP, East Bay Community Action Program, or EBCAP, and Tri-County Community Action Agency. So those 8 health centers together serve over 220,000 Rhode Islanders. Many people are surprised that almost 20% of the state's population seeks care at a community health center. And 86% of the patients that go to community health centers have incomes below 200% of the federal poverty level. So for a family of 3, that's about $53,000 annual salary. So you would think, okay, the majority of people that come to health centers are either uninsured or Medicaid eligible. It's true, the majority across the health centers, majority of patients are Medicaid eligible, and so it's about 51%. But 27% are commercially covered, and then about 10% are uninsured. So how are health centers paid? And Maria, I think this is pretty informal. If people have clarifying questions, they should just feel free to interrupt me, right? Okay.
Or if you could put them in the chat and we'll let you know.
Okay, great. So the way that health centers are paid, generally with commercial payers, they're paid the same way that a private practice would be paid. It's a negotiated rate. They are paid specifically by Medicare and Medicaid. They receive what's called an encounter rate. So every time a patient who's Medicaid or Medicare eligible comes in to the practice or the health center, or there's a telehealth visit, that encounter is reimbursed. And the encounter, compared to, say, what private practices might be paid for evaluation and management services, it's high. It's an average of $250 per encounter. So many people think, oh, well, health centers, they should be fine. All their costs are covered. But in fact, that's not true. So originally that encounter rate was based on the costs to provide care, but that was set in about 2018. Since 2018, that encounter rate has been increased by an index. That index is not equivalent to the rate of cost increases. So personnel costs, just costs of supplies, the cost of providing health care has far exceeded that index. So what's happened is, over time, there's been a big gap between the cost of providing care and the reimbursement received. It was markedly, the gap is very clear in Medicaid. There's not a lot of Medicare eligible beneficiaries in the health centers on average. Some health centers do have more, but this is really a Medicaid issue. And the reason it's an issue is because if Medicaid isn't covering costs, then the health centers have to use other sources of revenue to make up for that. And those other sources are their federal grants, a drug discount program. So that was the situation last year, actually for several years, but we were successful last session in getting the rates increased. So I'm not actually, I was going to set my timer. So I'm going to maybe stop because I think I've gone over my 10 minutes. But I just want to say a little bit about the rate increase. it's great. Like, we were very happy. It was a $4 million general revenue investment. The challenge for us, though, is the payment methodology itself. It's not sustainable. It's still connected to productivity. So the more you continue to rely on payment methodologies in the primary care system that have to do with the production of goods and services, you just don't have the flexibility to be able to provide the care that the patients need. And you're still on that hamster wheel. So I have a bunch of other stuff to say, but I always underestimate the amount of time. So let me stop. And then if there's time, I can talk about it in the discussion.
There's just one thing I'd like to ask you before we switch over to Frank, and that is if you had a magic wand and you could make one thing happen in the legislative session that would increase our access to primary care for the populations that you serve, what would it be?
I really do think we need to, I mean, this is a little bit more practical than if I actually did have a magic wand that I could do that. But I do believe we need to move to a capitated methodology. We need to get the amount right first. So there's no point in moving to a capitated methodology if the amount that you're paying is still not covering costs. So, but we do need a methodology that frees the providers up to deliver the care they need. We need to look at the cost of team-based care, and this might be seeds for the legislation. Look at that cost, and then and think about how you deliver it, because everything's connected: the amount, the payment methodology, and the model of care. We have to think about those three in conjunction.
That's excellent. If anyone has any questions, please put them in the chat. And we're going to move right along now to hear from Frank D'Alessandro and his very exciting new adventures.
Thank you, Marie. Thank you very much. And good evening, everyone. My name is Dr. Frank Michael D'Alessandro, and I would like to discuss our membership program that we just instituted at MDRI Primary Care. As Marie said, I'm a Rhode Island native, a graduate of Boston University with my MD from Ross University and residency training at the Yale Waterbury Primary Care Program. I practiced primary care for over 30 years, co-owning a large group with 20 sites across the state. And my mission has always been the same: answer patient calls, provide same-day visits, reduce unnecessary ER use, and focus on prevention. I've worked in independent practice, private equity models, and corporate medicine. Those experiences shape what I'd like to share tonight. In 2017, financial strain pushed our group into private equity, then into Village Medical, which is owned by Walgreens. The corporate focus was clear: financial metrics first, access and relationships second. During COVID, our urgent care centers were closed when patients needed them most. ER use spiked and patients were left frustrated. So in 2023, when our non-competes ended, I launched MDRI with Jonathan Martin and Dr. John Chichi. In just over a year, we've grown to 3 sites, 14 partners, and expect 20,000 patients by the year's end. Volume is strong, but financially, even a practice this size is very fragile. And our choices are limited what we can do. We have a high volume option, which is only sustainable by burning out providers. There's also a concierge care option charging $150 to $200 a month, which is unaffordable for most families. There's also direct primary care charging $60 to $100 a month, but patients resist paying on top of premiums. We can also charge administrative fees, but that's often prohibited under contracts or Medicare rules. That's why at MDRI, we're piloting a membership model at $10 a month, $120 a year. It's affordable, fair, and scalable. The program does a few things. First, it offsets the hidden administrative load, the prior authorizations, referral coordination, and appeals. Second, the membership's fees support the offering of non-covered medical services, such as a 24-hour expedited phone line, a nurse wellness manager, and advanced screenings like calcium scoring, genetic testing, and metabolic assessments. The structure is also essential for compliance. By ensuring that these fees support non-covered services, we remain within provider contract requirements. And both private insurance and Medicare permit membership models when implemented this way. And critically, it creates predictable revenue to increase staff pay, hire additional team members, and keep our offices well-staffed and welcoming. That directly improves the patient experience while reducing burnout. So for every 1,000 patients, the model adds $120,000 annually, money that goes right back into people and care. But there are barriers. Insurance contracts prohibit administrative fees unless contracts are renegotiated with the insurers. And also, implementing this membership model takes time explaining the program when you're already busy in the office. The solution is clear communication before visits through email, text, and check-in. When patients understand this model, most are strongly supportive. Legislative support is also essential. Rhode Island's Primary Care Preservation Act, actually introduced by Marie Hopkins, and it's HB 6353, was introduced earlier this year, and this allowed for a modest administrative fee for non-Medicare patients without contract renegotiations. However, it faced pushback, but it is expected to return in the next session. The reality is this: independent primary care cannot survive without sustainable funding. And my message is simple. Primary care is the foundation of our healthcare system. The corporate models have failed, and a modest $10 a month membership, carefully structured so fees support non-covered services, is a practical, equitable way to sustain practices, support staff, and preserve patient access. So that's what I wanted to say. Thank you.
Oh, thank you, Frank. So I'm certain that that will generate some questions specifically from the very well-informed audience that we have today. So I want to first read off a question that we got from Phil Chan. Thank you so much for being on the line. He says, "Good evening, everyone. Thank you for hosting. Good to see everyone. I struggle to understand how to address increasing reimbursement rates for PCPs." And this is a question that I'll pose to Elena. I believe that rates are set by CMS for Medicaid based on an index that Elena mentioned. Can someone talk a little bit more about how this could be achieved, increased, from both Medicaid and private insurers? Elena, you want to take a first crack at that?
Sure. So for Medicaid, it's the fee-for-service rate that the state sets, and there's actually very little that is paid directly by the state to providers because Rhode Island is a high percentage Medicaid managed care. So the Medicaid managed care plans, they determine the payment rate pretty much in the same way as insurers. So it's really about a negotiated rate. One of the provisions, one of the laws that was passed, I think in the last session, essentially set the Medicaid fee-for-service schedule as the floor. So no Medicaid managed care can pay less than the fee schedule. But it's really if I'm not understanding the question, Phil, it's really about being able to document that the increase needs to be made. So it's not like there's a set formula that can't be changed.
Yeah, thank you, Elena. Yeah, I've struggled, and this is for everyone. So good to see everyone. Good to see you, Marie. It's been a while. And Mike. So so just as a state, I struggle to understand a little bit. I've heard conflicting things about whether or not the feds and CMS set some of the Medicaid or Medicare rates. I know there's a fee-for-service kind of baseline rate. Is it like, does the state legislature set that? Is that set by EOHHS? So who do we have to like convince basically? Or is it the Medicaid managed plans, but then doesn't EOHS oversee them? And so doesn't EOHS have some pull in what those rates should be?
Yes, definitely. For Medicaid, it would be EOHHS that we would want to advocate to initially. And then if it doesn't show up in the governor's budget, then, we need to go to the General Assembly to advocate for that. I think where it gets confusing is Medicare has a very specific formula, and Senator Whitehouse talks about this quite a bit because that formula results in Rhode Island physicians being paid a lot less than Massachusetts and Connecticut. And that's actually a set formula. So that would have to occur at the federal level. But for the state Medicaid, if so for example, the rate that the health centers received, EOHHS then would direct the Medicaid managed care organizations to reflect that increase in their rates. Does that help?
Yes, thank you. I think I was getting confused by Medicare and Medicaid. I knew that Medicare was set by CMS, and I also thought that Medicaid was as well, but that makes sense. So at the end of the day, it's EOHHS who makes the call and directs the Medicaid managed care organizations.
Correct. Yeah.
Okay. And is that, just curiously, is that the Medicaid director or are we talking like the secretary? Or both?
Yeah, I guess both. And I think we would have to outreach to both. I will say that the Office of Health Insurance Commissioner was mandated by the General Assembly last session to conduct a study of primary care rates. And so the insurance commissioners, I'm not aware that he's issued a description of how his office is going to pursue that. But when we were supporting that, we said one of the things that we would like OHIC to review is what is the true cost of team-based care? Like, what would it really cost a practice to provide the model of care that we all believe is the way that primary care should be delivered? So I think that that's going to be part of what he does. And then that should influence how Medicaid and commercial insurers pay.
Great.
Thank you.
Thank you. So we have a question about the confusion between Medicare having set rates. If they're setting rates at a national level, how could Rhode Island's rates be different than Connecticut and Massachusetts? Elena, you want to take a shot at that?
Yeah, it's because of the inputs, and I can find a brief that the Congressional Research Service did, but it's because of the inputs into the formula for the Medicare fee-for-service. They historically have always not fully recognized Rhode Island, and I don't know the specific inputs, but just over time, the gap between us and Connecticut and Massachusetts. So because it's regionally based, so I didn't mean to say that Rhode Island, Connecticut, and Mass all get the same. It's not a national Medicare fee schedule. It's different by region.
Okay. And then a question for Frank. You talked about your hope to be able to charge an administrative fee or to have an optional membership fee for your practice. And Elena talked about her dream, which would be to go to a capitated rate. Have you thought about the impact of a capitated versus fee-for-service impact on your practice, considering that about 30% of your expenditures right now are going to pay for overhead because of fee-for-service billing? How would that work for you?
Basically, we're trying to do, you have to figure out what the number is for a capitated rate, and we've come to the conclusion, at least in a private practice, it's about $40 per member per month in a typical suburban practice. The gulf is what the insurance companies think that we should be getting, and I think that number is in the low 20s. Um, In fact, the reason we're charging the $10 is to get our the equivalent of a capitated rate up to $40. So we think we're probably getting close to 30 if we look at our, what we get fee for service and divide by the number of patients. So the $10 membership that we're doing or administrative fee, that's only to get us to that point at that $40 per member per month. For our practice organization, we think that's enough. But for other practices, it may be nowhere near enough. I mean, there are some practices that if you want to, provide the full services of primary care with nurse case managers, for instance, you may need $60 to $70 per member per month. The problem that I'm seeing is the gulf between what the insurance companies think that they want to pay and what we actually get. So we're just trying to, but what we do know for sure is that if nothing changes, you've seen what happened to Anchor Medical, and that happened very quickly. I can see any large practice, even a small practice, rapidly deteriorating within a matter of months. And so that's why we want to keep ahead of this with this growth that we've had and try to get that. But ideally, if we could get a capitated rate, that would solve a lot of our problems. It would certainly reduce all the billing fees that we pay just to collect the money.
Right, and Deborah's saying that if we actually identify that actual cost of team-based care, where would the money come from to pay for that? I'm not sure if either one of you has the answer to that, other than either private insurance, I think Frank was identifying. And Elena, if we moved to a membership model on Medicaid, for instance, how would that work? And would it be a waiver program?
It would be a waiver program. Generally, it would be hard to, I could not guess how this current administration would respond to a membership model. Historically, Medicaid has steered away from this notion of requiring Medicaid beneficiaries to pay themselves. So if the question though is if the state on the Medicaid beneficiaries' behalf paid a membership model, I don't know, I'd have to think about how is that different than a capitated model. And you'd have to really price that membership fee well, because from an actuarial perspective, the utilization is just very different across the commercial. If you look at commercial and Medicaid utilization, especially the reasons that people are on Medicaid, the majority of them are, families and children or expansion groups. So the costs aren't super high, but then there are people who are on supplemental security income, and their utilization is much different.
Well, I don't see any more questions in the chat. So I'm actually going to say thank you to all of you for tuning in. We just went over by a few minutes, and that's all that we have time for right now. But Dr. Fine, did you want to talk to the folks who are on the line before we sign off?
We can't hear you, Michael.
There we go. Sorry about that. Many thanks to Marie, to Frank, to Elena, and all the people who are involved with preparing this presentation tonight to give us a place to stand, to stop admiring the primary care problem and start fixing it, remembering again that the three legs of the primary care stool are 1, reimbursement, 2, workforce, and 3, workload. It always astounds me that we spend so much time having to think about primary care reimbursement, remembering that as a nation, we spend about 3.9% of our total healthcare spend on primary care, even though primary care provides about 50% of the services, and actually provides most of the relationships that matter in order to help people get the care they need, when they need, where they need, and how they need it. And just to give you another little perspective, that means that per person per year, we spend about $575 per person per year on primary care, which is actually not significantly different from what we spend on police and fire protection or water and sewer, or any of the other basic services that we provide to everybody, regardless of where they live or how they live. And if we can do that for basic services, we ought to be able to do it for the essential health service we call primary care. So to move this forward, please consider talking to your state senator and representative about what you heard tonight. Remembering that what we're about is educating people about a couple of basic things. You heard from two different parts of this, of the primary care world, of the importance of moving to what we called capitation or a membership model, paying for services per person per month and paying fairly. Understanding, I think Deborah said that means we got to work on where the money's going to come from. But there are lots of different ways of finding that money from waste that already exists in healthcare, in all sorts of different places, with all sorts of different profiteering. And what we ought to do is reflect backward on the great work we did together in the last session and encourage people to be engaged and work on a number of different bills that I think will emerge about capitation and making sure we take care of the 44 to 67,000 people in Rhode Island who we think are likely to lose health insurance, either because they've lost Medicaid or lose access to health care through health source. That's a number that's coming up, but the time to prepare for it is now. So please be talking to your legislators and talk to each other. Please consider either joining or starting a local work group in your own community. Please also consider coming to the State House on October 9th at 5 p.m. There's a study commission on a new medical school at URI that will be hearing testimony, and hearing the voices of Rhode Islanders is important. Our next teach and learn in session is on September 30th. And that will be an interesting and amazing presentation from somebody who's really from Bryant Attaby, who's really got his finger on the pulse of health policy nationally. And, just keep doing what you're doing. Make sure that that everyone's talking to each other, and keep this centrality of getting primary care to everybody. Keep it on the table and make sure that everybody across the state's paying attention to it, because this is the way to make progress, building a healthcare system that's for people, not for profit. And that really does start by providing primary care to everyone in every neighborhood and community in Rhode Island. Thanks to all. We hope to see you next Tuesday.